according to the WHO, there are 11 million cases now of infection worldwide, probably a lot more than that, of course, over 500,000 deaths. Melbourne has just gone back into lockdown after coming out of lockdown 2 weeks ago. They've had a flare up there. And of course, in the US and also Brazil, those markets are not yet, or do not appear to be yet, at peak infection rates. In fact, both are reporting 50,000 infections a day in each country. So, you know, it's a mixed picture. But against COVID, battling against COVID, we have the ingenuity and dedication and entrepreneurship of not only healthcare professionals around the world, but also HealthTech. And I'm really excited to have 4 very interesting ventures who are going to talk to us this afternoon and the next hour about how they are using technology and lots of other techniques to battle COVID in markets around Southeast Asia and beyond, and China and other markets. Before I hand over to them, just to recap on the format, so we're going to hear very soon from our panelists. We're going to cover some topics that we think are very relevant to this topic, but please let us know additional Q&A, and in the box below on Zoom, I will test my multitasking skills and see if we can field a few of those as we go through the afternoon or the next hour. So without further ado, I'm delighted that we have Charles, Aileen, Carl and Ian joining us. I'm looking at Ian's quite windy looking background there. So let me hand over to the panel. So guys, it'd be great to hear who you are, your role. Just give us the elevator pitch to start off with about your venture. We are going to come back and talk a lot more about the venture a little later, but just give us the elevator pitch to start off with. So Ian, let's start with you.
Yeah, I hope you like my my windy background. Can you hear me okay?
We can hear you, yeah.
Right. Hi, good afternoon, everybody. My name is Ian Chapman-Banks. I'm the CEO and co-founder of a pure play artificial intelligence company called Scream Technologies, based in Singapore, but roughly operations in 40 countries, operations meaning we have customers in 40 countries. So if we kind of distill it down, what does Scream do? Scream is essentially an artificial general intelligence company that is using cognitive algorithms to predict human behavior. Machine learning and supervised learning really doesn't kind of work in this space of human prediction and human behavior. Therefore, we've developed our own series of algorithms to predict human behavior. And we're working across multiple industries, just very quickly. US intelligence, in terms of biosecurity, COVID-19 platform, pharma companies, and then a lot of work in the enterprise AI space and kind of the ad tech space. So that's me. Thank you very much.
Great, Ian. That really sounds fascinating. I can't wait to learn more about that. Let me go to Charles next. And Charles.
Hello,
yeah.
Do you hear me?
We can hear you now. Yeah.
Okay. My name is Charles Bark. I'm the happy founder and CEO of Hainunu. I'm very happy to be with you. Thanks to your wonderful organization and invitation, Galen Growth. Happy to be with my peers also in the same room. We did 12 years R&D for countries in the world, USA, Canada, France, and China, to be able to help seniors and also chronic disease patients, because 80% of them has a chronic disease, at least one, not only to live longer, but healthier and happier at home. And the way we do it is we have a complete full set of intelligent package, digital health, where we have DNA testing, we have also connected medical device, and also insurance like telemedicine with our partners AXA and Ping An. That's what we deliver today in Asia and also Europe.
Fantastic, great. Look forward to learning more as well, Charles. Carl, over to you next.
Thanks, Matthew. Great to be here as well. My name is Carl Nicholas Ng. I'm the Chief Operating Officer of Lifetrack Medical Systems. We have a next generation diagnostic imaging platform where we aim to address the problem that 2/3 of the world doesn't have access to medical imaging currently. So we work with providers in over a dozen different countries to provide affordable access using our software to medical imaging services. And part of that is geared towards addressing COVID indications, which show up in respiratory X-rays and CTs, which I'm happy to talk about later. And we're dually headquartered in the Philippines and Singapore.
Great, thank you, Carl. Thank you very much for that. Aileen, over to you. Oh, you're on mute, Aileen.
My apologies.
Okay.
Good afternoon, everyone. My name is Aileen. I'm the CEO and founder of HealthTech. HealthTech is actually founded after a post-management buyout of iHealth Labs. So we actually provide remote patient monitoring. I am personally based in Singapore, but our business generated mostly out of Australia as well as the US. And prior to COVID, we were really focusing on the managing of a chronic disease patient over a longer term. At the end of the day is to reduce the overall healthcare costs and as well as improve the quality of life of our patients. Of course, the topic for today is COVID. We'll talk about it a little bit more later. Thank you so much.
Thank you, Aileen. Great. Look forward to hearing more. And, you know, on the surface of these, perhaps your solution sounds not maybe dissimilar to perhaps what Charles is doing. So, Charles, back to you. You know, I've looked a little bit about your service, and I can see you're doing some great work with the elder population. Tell us a little bit more, just to start off with, about how you're approaching what you're trying to solve. Perhaps tell us a little bit more about where you're operating in.
What we try to solve is, as you know, many countries face this kind of tsunami bombing issue of senior care, because you have baby boomers everywhere, growing fast. But the question is, how is it possible to help them to live longer, healthier, happier, since we have a shortage of professional caregivers at home? That's number one. Number two, 80% of them have chronic diseases, and that was very obvious during the COVID period, because 70% of all the death toll come from the seniors above 70 years old because of comorbidities issues. And the way we help them to, number one, face this top issue of COVID, and also generally speaking before COVID, is number one, to try to first identify and assess the potential risk assessment of those cardiovascular disease, as well as diabetics type 2, be able to collect some data that we can measure. That's number one. The way we did it is through DNA testing, number one. And then the number two, the way we do another evaluation of the risk is from the IoT connected medical device that we bring to their home. So they can give another set of data based on the vital sign, and we cross data with our algorithm, those with DNA plus the vital sign, and we come up with another insight of the risk. And once we get this insight, we do the home monitoring for the chronic disease management. But we don't stop at that level, because what if they need and require specific medical assistance at home? So then we have built in our app this telemedicine 24/7, which is provided. We had two partners. One is AXA Partners, AXA Assistance, and we have also Ping An, the Chinese, one of the most biggest insurance company here, where we also can deliver telemedicine, but also accidental and death insurance up to 100 years old without underwriting. So I will conclude saying that helping the seniors is number one, evaluating the risk, try to be more in forecast of the risk, predictability with our algorithm,
Yeah.
Number two, when we got this visibility of the risk, or if they have already existing chronic disease risk, so then we monitor with a connected medical device at the home. And in case of issue, we have assistance of nurse and doctor 24/7 delivered by our partners, AXA or Ping An.
Mm-hmm. Yeah, very interesting. And if I'm an elderly person and I've done this, I've done my DNA, I've done my blood pressure, perhaps I've done the diabetes check, all of which is in the home, isn't it? Is there an alerting system from your platform to a healthcare professional? I mean, how does that two-way communication work?
Good question, Matthew. Of course, we think that gravital centers should be on the human side, not on the technology side, which is very important. So your question raised the importance of who is assisting them on top of the technology. So in-house, we have nurses who look at the data. We have also alarm system, not only to us, but also to the children. They have their own caregivers app where they can follow live their medical data, as well as the alarm system. So they will be warned if they have a specific issue. And the second thing is the assistance of our partners. We have some partners who can deliver home services for seniors, and they can use our platform where to deliver the right service in the right moment if there is any assistance to deliver at home. So this is one of the partners that we are very happy to partner with, because HealthNunu, we're not claiming to have all the full set of services, including at home, but countries per country, we try to partner with the best in class in home senior care as a nurse or doctors, and then they will plug to our platform and deliver the right services.
That's great. And I guess some of the technology there is perhaps for a more elderly person might be a little tricky, little difficult, you know, with things like even something perhaps we think is simple like blood pressure might be a little challenging for something that's a bit more elderly. What about the setup? Do you rely on family members to help the elderly with that, or how does that work?
Yeah, well, we had as maximum as possible senior user-friendly app first with a easy user experience to make it simple for them to use it. In terms of the setup, it depends on which kind of seniors are we talking, because we are seniors above 60 years old. But 60 years old is a healthy aging for many of them, especially in Asia, especially in China, where I live now. They can handle the installation of the app. Mm-hmm. And after they installed the app, it's kind of easy to use with our app. But if we're talking of more elderlies, like 70 plus, 80, of course, then it will be their children who assist them. Yeah. Yeah. Because the users of our wellness kit here is more the seniors, but in terms of the buyers, this is the children, right, who doesn't have the peace of mind, because they ask themselves, like me with my mom, how is it possible to take care of our parents when we live far away from them? Yeah. And so they buy the wellness kit, they offer to their parents, and they will install the app for them to use it.
Fantastic. Listen, I'm going to come back and ask all of you about how your solutions helped the COVID situation. And I also want to ask about the insurer piece as well, but we'll save that for a little later. Let me thank you, Charles, for that. Let me, Ian, come to you. Big data sounds like ingesting vast volumes of data and making some very interesting conclusions from that. Tell us a little bit more about that, perhaps in the lens of COVID.
Yeah, absolutely. So what we have an ability to do is by using our AI, and as you quite rightly said, ingesting probably 85 to 90% of all the unstructured anonymous data at a country level, we are able to predict both geospatially and behaviorally what people are doing. So kind of let me contextualize that in the COVID-19 world. So somebody goes into the Institute of Infectious Diseases in Singapore, they have the test, they're diagnosed with COVID-19. All we need is the home address and 2 places they've been to in the past 24 hours and 2 places they haven't been to. With a 95% accuracy, we will be able to understand probably within 2 to 3 minutes, maybe 5 minutes tops, every device that they've been in contact with less than 1 meter for more than 20 minutes. Now that parameter is set by the country and the government, but generally it's normally about less than 1 meter. It's normally about 20 minutes. That's a default for a number of countries. We'll be able to go back in data and find everybody they have been in contact with for the previous 14 days. Then once we get, let's call it those markers, those device IDs, we can then actually then understand everybody that they've been in contact with since they were in contact with the COVID-19 sufferer. And depending on the PII situation in the country, depending what the government wants to do, we're able to give them various levels of information which would allow them to either message that person directly using our Scream ad tech, or they can resolve their home address, even if it's an apartment complex, and they can go around to apartments and serve them in Singapore, it's called a stay-at-home order, 14-day quarantine order, for example. But more importantly, once we've understood the gravity and the intersectors, we're able to actually predict where the future clusters will be. So we call that, initially it's backward tracing. In other words, somebody who's been diagnosed with COVID-19 will find out everybody that they have been in contact with, and they're then contacted. And their contacts are then contacted, and the engine does it all automatically. But more importantly, if you want to get the R number down to less than 0.5, which means there's going to be, the virus will eventually die out, you have to be able to forward predict the clusters that will occur, close them down, and actually test those people before they even become symptomatic. Well, no, symptomatic is the wrong word, infectious, because you can be asymptomatic. So that's what our platform does in the COVID-19 world.
Ian, let me just ask you a quick question there, because I'm fascinated by that, because of course, you know, a lot of governments, and I'm thinking actually of the UK in particular here, a lot of controversy about tracing apps, the ability of Bluetooth detection amongst iOS, etc., all of that stuff. So it sounds like you're able to do some of this work on like a more macro kind of population level. Is that the right way of thinking about it?
Yeah, absolutely. So if you think about Bluetooth just for 30 seconds, the average Bluetooth signal, unless it's a really brand new iPhone with the new updated Bluetooth receiver, probably between 25 and 50 meters is the range. So what does that mean? So if you're in your car and you're sat in a traffic jam, you are automatically connected to every other car, and they then become basically contacts of yours. So automatically, huge number of false positives. If you're sat at home in your apartment block, everybody above you, below you, to the right and left, automatically become potential victims. You sat in a restaurant or you're in a gym, everybody next door within 50 meters, no matter how many walls there are, will become potential contacts that need to be traced. So Bluetooth gives a very high number of false positives. Plus, how many people download the app? If you download the Apple and the Google Trace app, especially in Google, it kind of turns itself off a lot. Apple, you go onto, your screen goes off, the app goes off. So, and then how many people download it? 20% of the population. So look, it's a fast, easy solution. But if COVID-19 stays around, how we now think it's going to stay around, it's not a solution that is going to be realistic in the short, medium, or long term.
Yeah.
Now, what we're able to do is we're able to passively survey every device ID in a country. So actually we're covering, in Singapore, we've got over 6.9 million device IDs in our database, which is more than the population of Singapore, because some people have, 2 or 3 devices. So what we're able to do is passively anonymously survey whole populations. So in the UK, for example, where we've had extensive discussions with our good friends at NHS, NHSX, who are actually the 3rd largest employer in the world. I didn't realize that until I started talking to them, biggest employer in Western Europe. And the cabinet, the UK cabinet, we've had many discussions with, and what they're very concerned about, even though our tech stack is actually GDPR compliant, there is privacy PR elements to people being alarmed. So what we've done for the Western governments that care about this is our data is encrypted, double encryption. So actually the engine just comes out, if you automatically uploaded 10,000 people with their home addresses and 3 places they've been to, the engine would then basically spit out in probably about 30, 40 minutes, all of the particular places and buildings that these people live in. And then you can actually go and close down the buildings or knock on people's doors or send messages or send SMSs. So privacy in this respect it's not so much that privacy being affected. Quite rightly, people are very nervous about government having too much data. And they're very worried about being able to track people. There's cases about, in the early days about people being in places they shouldn't have been and they got caught out. That is not possible with our platform because you can only put the person's home address in, and this is not 3D map. This is basically, it spits out all the information in a dashboard, and then it's cloud hosted, and then basically every 24 hours, actually the data resets itself.
Very, very interesting. Would love to know more. We may get some time to come back. Let's hope we do. I'm just going to flip though now. Thank you for that, Ian. To Aileen. Aileen, tell us a little bit about what you're doing with HealthBeats, and in particular, how does your solution, how is it helping with the COVID situation?
Thank you, Matt. So when HealthBeats was first founded, we were really focusing on the notion that everyone deserves better healthcare beyond the hospital setting, and we want to bring healthcare outside of the hospital setting into home. So we started by focusing on chronic disease. We had requests for post-hospitalization for the reduction of readmissions. So some of the projects we deploy is, for example, with the Australia federal government funded agency, Murray PHN. So Murray PHN looks after a very large geography area, about 100,000 kilometer square space of Victoria, which is now in lockdown. and they look after about 380,000 chronic disease patients. So it's a huge issue, it's a huge healthcare cost. So we work with them in trying to route remote monitoring to them for a couple of reasons. One, remote monitoring is well known and well studied to be able to help to cut admissions. And at the same time, we try to improve the quality of life for individuals. So that's what we do previously. And as we were moving in that direction, and of course, COVID hit. So when COVID hit, we realized that as a startup, we don't have a lot. We don't have a lot of funding. We don't have a lot to offer in this situation. But we are on the ground. We see patients rocking up to hospitals and rejected beds and treatment, no ventilators, and all the crazy stuff that go around in the US or in Australia where we operate. So we actually tweak our solution to try to offer it. What we have is just a ready platform. Anyone can get on it like immediately. In COVID, everything is yesterday. So we try to tweak it and try to see what we can do to help. And we extend our platform to patients, the COVID patient that cannot receive healthcare, to at least receive a minimal care or monitoring on their own or be at home. So at least they understand whether their condition has deteriorated, whether their condition has improved or they are well. So what we do is we actually work with hospitals So on average, for example, in the US, some of the hospitals we work with, every day they have about 500 to 1,000 patients walking up to the emergency room and turn away. So it was a very sad sight. So what we do is we provide the devices, mainly a thermometer, and as well as a pulse oximeter for blood saturation monitoring. And we give the kit to the patients. They bring it home with them, they monitor their condition regularly, and for any deterioration, they revert back to the hospital and immediately say, is there any bed? Most of the time, they still don't have it, unfortunately. But this is really the minimal thing we can do at this juncture. So ever since the last few months, our solution continued to expand into research institutions, because most in the US, a lot of research universities, institutions have their own medical centers as well. So because of that, we are also supporting researchers seeking out vaccines as well as cure in monitoring and doing their pilot, in doing their clinical trials in searching for potential vaccines in a digital way, instead of monitoring the patient in a manual method. So, so COVID has indeed, whilst what we believe does not change, we still continue to focus on the patient on chronic disease. Whilst we have this couple of months moved a lot to try to support whatever we can in the COVID situation. It is very interesting, is a lot of people actually also probably already realized by now, we might have millions of COVID patients. We also have millions of currently sick patients that have no access to healthcare because of COVID. So all their existing appointments, procedures are delayed or canceled because of the lack of facilities in the hospital. So it makes remote monitoring all the more important, even including advanced cancer oncology, where they can't seek treatment at the moment during that period of time. So yeah, sorry, Matt. Yeah, so what we're trying to do is to really look after the patient, the existing patients as well.
Fantastic. Let me understand something a little bit, which is the device. So does every person on your platform, do they have the device to measure blood oxygen and temperature?
Yes.
Or is that like an optional? Okay.
So because of COVID, it's almost impossible to get devices.
Yeah.
So whilst everyone come to me and say, I need this, I need that, that's like, okay, so we were trying frantically to seek, it's just that everyone's seeking masks and PPEs, right? So of course, through our relationship with the device manufacturers, we managed to get pretty substantial amount. That is one part. The other part is also what we do is to make it flexible. So one of the tweaks we make to our platform, make it available for COVID, is that we even allow patients to bring their own device, BYOD. Because they will come to a stage that probably a lot of households already have a thermometer. Maybe not the ideal infrared, non-contactless, but even if it's a normal in-ear model. So as long as there's a device, they can still input and send all this data real time to someone that is monitoring them for their condition and to take proactive measure of their health conditions. Yeah.
And just in terms of sort of the monitoring piece then, so, you know, if my blood oxygen is at probably a low level and I've got a high temperature, what happens is there an alert that goes to the healthcare professional, or is it a kind of platform algorithm type alert? And then what happens? Is there some kind of triage that might happen before I go to the clinic or the hospital?
Right. So what we do is, so it depends from hospital to hospital and organizations to organizations. So the platform actually provide initial alerts. So a standard impact to low oxygen level is, for example, 94%. Once you hit 89, it's bad, right? So we have a standard threshold where once you hit the alert, the data are sent real time to the care providers. The reminders through SMS or email are sent real time either to the patient or as well as to the providers. And having said that, it depends on whether the provider is going to take action. Right? Everyone is swamped and overwhelmed. So it definitely depends on hospital to hospital how they are coping with it. The platform allows that. We can do an initial triage based on the alerts, for example, to remind them to talk to their providers. But whether they can get resources is another challenge.
And in terms of the, I mean, last question for now, but in terms of the overall benefit, when you look at COVID, is it perhaps that, you know, somebody that might be worrying that they have COVID, but with your device or a BYOD device and the platform, perhaps, you know, actually it puts my mind at rest that actually I don't have COVID, therefore I don't need to go and impact the healthcare professional. What are some of the benefits to the healthcare system of your platform?
Right. Well, since it's not a cure for sure, remote monitoring is probably one of the best solutions. So many COVID positive, I wouldn't call them patient, are asymptomatic, right? They have the virus, but there's nothing, no fever, nothing impacting the oxygen saturation level. So they're perfectly fine, healthy. The remote monitoring doesn't do that. Only swab tests can prove that. So the minimal thing is for especially high risk group, we know, like elderly. Another high correlation is hypertension. That means high blood pressure actually somehow correlate to high rate of morbidity. So mortality. Sorry. So in that sense is that once they start to monitor, mainly this group of patients, they are a lot more concerned. So they do actually monitor pretty consistently. In fact, more than what we recommend, because I think people are living in fear. But I think it assures them when their numbers doesn't drop, and they are assured that after 1 week, after 2 weeks, if everything is good, at least they are a lot assured. Yeah. Especially in this lockdown situation, one of the situations we realize is a lot of family members are living apart or forced to live apart and not see each other. So there was a lot of concern how their loved ones can be looked after. So I think this is probably the minimal thing that is clinically can be used to track the health of their loved ones.
Yeah, I'm sure that's very reassuring for not only the patient or the person that's on the platform, but yeah, their relatives as well. Thank you, Aileen. Hey, Carl, over to you. And you're occupying, I think, quite a different part of the health sort of ecosystem with medical imaging and aiding perhaps the productivity of that. Tell us a little bit more.
Sure. Thanks again for inviting me to the panel. So as I said in the introduction, the problem we're trying to address is 5 billion people around the world don't have access to medical imaging. And if you think about it, that's a problem because medicine is becoming imaging centric, if not imaging first, as a doctor phrased it to me. So whether it's pneumonia, you need to get an x-ray, the cancer, you need to get a CT scan. And one of the issues with why medical imaging doesn't have as much access, it's no longer just the cost of the machines, because you go to a hospital in a second or third tier city in Indonesia or the Philippines, they're going to have a CT, which, you know, to me was surprising. The real issue is how available are the specialists who can do the diagnosis on those machines. You look at Southeast Asia, I think on average in emerging markets in the region, there's one radiologist for every 100,000 people. And those radiologists are using or have to use expensive legacy software, which sits on premise in the hospital, which means that they have to be physically at the hospital. And there's a lot of things there where if you start looking at the geographic distribution of specialists, where they're mostly concentrated in big cities, and where most of the population is, there's that imbalance. And second is if you're looking at the big cities themselves, you know, Manila, Jakarta, or Bangkok, or Ho Chi Minh, you're talking about them moving from hospital to hospital, being stuck in traffic simply because they need to be physically present at the hospital. So what we've done is we've designed our next generation imaging platform to work for affordable access, particularly in emerging markets. And there's a couple of elements around that. One is that we designed it to be accessible in low bandwidth conditions using consumer grade hardware. So effectively what that means is you are a radiologist, you can be working from home using your laptop or your desktop, and you don't need the quote unquote medical grade monitors that cost $20,000. And you don't need the VPN into the hospital server because our architecture is designed to be hybrid cloud. So you can have an on-premise server, but you can also have a cloud server that synchronizes seamlessly with the on-premise one, so that the clinicians at the hospital are getting the reports in real time as it synchronizes with the cloud. The practical effect of that is that we expand the reach of these very scarce specialists. We save them time from hopping from hospital A to hospital B. And third is because our CEO and founder, Dr. Eric Schultz, is also a practicing radiologist himself. We built in a lot of productivity enhancing tools into the software. It's not particularly AI, but more on automation, so that you can make the radiologist 2 to 5 times more productive, meaning they can see 2 to 5 times more patients in the same amount of time. Our target customers we're not B2C, we're B2B, so we work with providers. And so the pitch to providers is, we can reduce your investment in operating costs in using our software, and we can allow you to expand access or service offerings around medical imaging seamlessly. So, one of our success stories is we work with the largest primary clinic chain in the Philippines. They've gone from 3 clinics to 78 in 3 years. There's not a single radiologist that bothers to go to the clinic in any of their locations. They have an X-ray. They have nurses that operate the ultrasounds and radiographers to operate the X-rays. They send it up to the cloud, and the radiologist is reading from home and able to read across the entire network. And from a patient experience point of view, instead of having to go back in 2 to 3 days for your report, because the radiologist only shows up once a week, maybe, you're able to get your report within 15 minutes or less. So when COVID hit, obviously there's a lot of advantages for the model of delivery that we enable, because a lot of the healthcare providers were didn't want clinicians coming in as much as possible to minimize the potential vectors of infection. But B, what we also saw here, at least in the Philippines where I'm currently at, is the government instituted like a full-scale lockdown. So there was no transportation. So the project that we did was with one of the provincial health authorities, where their radiologist, who was at the hospital, was actually commuting between 2 different islands. So she was stuck in the other island, and so you had a CT that was basically an expensive doorstop sitting in that island. And so we managed to set up our solution remotely, and they've been using the CT to do triaging on potential COVID patients since then.
Fantastic. Well, that's a really practical example of technology in action there. I'm just curious, I mean, so the hardware can remain the same, by and large, the same hardware and you just have the software layer sitting on top that allows access.
Correct. Yeah, we're pretty much like the infrastructure. Yeah.
Yeah. And does that extend to, I mean, are you looking at things like augmented assistance for the radiologist in terms of, yeah. Do you
so I mean, I think, and I know Ian does a lot of work in this space. It's been interesting to see how AI has taken off or met resistance during the COVID period. Our approach has always been, it's an open ecosystem. There's a lot of different AI, companies working on different parts of medical imaging, from X-rays to CTs to ultrasounds. We'd love to work with all of them. We have an API so that they can integrate into our software. And it's basically for the providers. We look at it as we're the app store. They are your apps. We're iOS maybe. Or maybe that's a better analogy. And if you are looking for a particular solution, we can deliver it. What we saw, interestingly, at least from experience in the Philippines, is Huawei actually came in with offering their AI solution for COVID triaging. And basically, they approached one of the government leaders in one of the provinces in the Philippines. He imposed it on the hospital in his area, and there's this huge backlash from the medical establishment, particularly the radiology college, where they said they weren't consulted and they didn't want to accept, or basically the AI solution hadn't been tested. So I think it's early innings for AI or augmented intelligence for imaging diagnosis. There are going to be some early adopters, but there's still also a lot of resistance and suspicion among the medical community around it. So our approach is, if we do find a partner that would like to implement it, then that's available. We introduce them to some of the other AI partners in our ecosystem, and they can select which ones they're most comfortable with. But we don't come out and say, look, this is a priori, you should be using this already.
Got it. Yeah. Okay. Carl, thank you for that. I think it's very, very interesting what you've just been speaking about, because you sort of discovered that through COVID, there were these sort of practical issues. It wasn't necessarily the machine and the expensive hardware. It was maybe getting to that hardware or accessing the imagery that machine is capable of producing, and getting that whole piece to be a lot more productive and efficient. Which sort of poses another question in my mind, which is, perhaps for the rest of you, have you seen, has COVID exposed some other gaps in healthcare? Ian, maybe come to you on this. I mean, with your sort of kind of helicopter view of how COVID is impacting populations and healthcare, what gaps do you see, and where do you perhaps see your service helping plug some of those gaps?
Yeah, absolutely. We have another platform that we make available to the big pharma companies. So we're working with probably 12 out of the world's biggest 14, 15 pharma companies. And what we're able to do is we're able to predict at a very high level accuracy what HCPs are thinking. And in response to that, for our pharma clients, how do we reach them and how do we message them? So it's one very clear thing that's happened, is that the whole HCP community has started thinking in a very different way. So for example, if you were doing research last year trying to understand HCPs, then that research no longer holds. In fact, we ran messaging in January and February and looked at it last year. And actually, it's not just changing year on year, it's changing week on week. So HCPs are going to different digital sources. I would say now that maybe 100% of HCPs are online, and digital journeys that these HCPs are on can be understood. And then you can serve up the right content at the right time if you're a pharma company or if you're a government. I mean, in South Africa, we are messaging populations about cleanliness and what to do for COVID-19. And we're actually sending them up front 1 and 2 minute cooking videos of how to cook at home when you're locked down. And that then goes into the government keep clean message. So we're kind of using our AI for governments and or pharma companies to understand how human behaviors change dramatically, completely different to December, January. It's changing weekly. And then really, how do you actually keep research up to date? You literally have to go digital, because what HCPs are thinking about changes based on events which are magnified in the news. They watch the news, they learn more things, they go online. So this is a very rapidly changing ecosystem. And to understand insights, you really have to go digital.
Yeah, very interesting. Charles, slightly different question to you, perhaps, just following on from that. I mean, in terms of sort of elderly care, perhaps thinking about China, for example, and also kind of the provision of healthcare and in terms of funding it. I was very interested to what you were saying about the role of the insurance partner in your proposition. And you mentioned, I think, that AXA were doing 100% free of underwriting for anybody, I think, on your platform. Is that right? How does that work?
In fact, it's not AXA, it's Ping An.
Right,
they're doing free underwriting for seniors up to 100 years old for accident and death. This is not a healthcare insurance, this is accidental and death insurance. So once a customer on board in Hainunu Wellness Kit, that's already embed these insurance services. And so everybody are insured with this solution. So what does it mean practically? That means that if they get an accident in their life, they will be reimbursed up to a certain level of expenditures by this insurance. And unfortunately and sadly, if it's happened that some of them may die, then the family will receive a lump sum of 100,000 Renminbi, which is around $12K for this compensation. Of course, it will not compensate the loss of the human life, of course, as you may understand, but it will compensate to a certain level of expenses. So this is how it works. And insurance like AXA or Ping An are willing to bring this kind of protection and comfort to this senior care segment, which is booming in China, because today we have around 250 million seniors, and within less than 30 years, it will double to 500 million. So big organizations are like payers, like insurance, are concerned about who will pay for these growing expenditures, especially for chronic diseases. It's better to be in preventative than just a post-accident and post-treatment. So if we can have this kind of full integrated solution that, number one, identify in prevention or prediction even before they can have it, that's also another concern of them today. That's why with HiNunu, we are not at the beginning, we were focusing on the 60 plus, but now we get down to mid age to be able to identify potential person at risk before they develop the CVDs.
Great examples there. I always find the numbers in China staggering, but it's great that your platform is really helping on that preventative piece, plus, the reassurance perhaps of that Ping An product there as well. Let me ask a slightly different question for Aileen, which is, clearly COVID has been a massive impact on HealthTech and the whole healthcare system. As we saw, I don't know if we're anywhere near really the new normal, but as we get to perhaps post-peak, what are your thoughts on your service? Do you expect the momentum that you've seen to continue?
That's a good question, Matt. Actually, I expect the momentum to pick up. So the reason is, whilst we have an immediate momentum in COVID, a lot of times it's very knee-jerk reaction. I just want it now, and because I'm just struggling, and so we are just also in the knee-jerk reaction trying to help the hospital. But in the longer term, it's not going to work like that. In the longer term, there is a lot of improvements and a lot of re-strategizing that the hospital need to look at. This is apparent in every country. With COVID, actually shows a big gap in the current healthcare system everywhere. So when things start to settle down, that is where people, when everyone has the time to sit down and say, okay, what should we do now that COVID is settled down, we are not that busy, what do we really need to move towards strategically? It have to be remote, because everyone realized that is the biggest piece that was not done. And when that happened, I do envisage a lot of funds and money from many areas. For example, we are already talking to a lot of people from government to insurers, to even very large companies, whether it's pharmaceutical device company, that is moving in that sense. So remote in many areas, telemedicine is big. So a lot of funds are going to come in, and then people are going to look at deploying them for real, and to embed it as a part of the new normal. It has to happen. Yeah.
I was going to ask you actually, because you have obviously software development, and then you have the device as well. I mean, how now is that funded? Does somebody in the value chain pay for some of this, or how does that work right now?
Because of the market we operate in Australia and US, the people don't pay. The government pays. Okay. Or yeah, if there's insurance involved, the insurance pays. So essentially at this juncture, because of COVID, there's a lot of temporary stopgap measures. For example, there's a lot of grants going around everywhere. Money is no longer really a big issue at the moment yet. So there's a lot of grants going out for people to embrace remote monitoring. But these grants are, after all, temporary. So during the pre-COVID day, when we are actually supporting chronic patients and post-hospitalization, it is still not the patient that pays. It is still the government and the insurers who are seeking to reduce the cost of admission, overall healthcare costs, and they're trying to motivate people to take proactive care of their health. So they are the ones bearing the most cost. Probably the region that can get the patient to pay most is probably Asia, where where universal healthcare or coverage is limited. Then that is where there is a there's a private layer of healthcare where the rich and affluent can pay a little bit more. Yeah, but other than that, most of ours is funded by fully usually by the government or the insurers.
Okay, thanks for answering that. I'm going to take a few. We've got about 5 minutes left. I'm just going to see if we can take a few questions from the audience here. So, Ian, I've got one for you. Actually, I had the same question, which is, you talked earlier about sort of contact tracing. Clearly, location has some, big part of that. So, question, Ian, where do you get the location and device ID data sets from? Are they from the telco? How do you ensure that they stay anonymous and privacy compliant?
Yeah, absolutely. So, unbeknown to most people, there is within the ad tech ecosystem, every time you download an app, you give the app publisher the permission to actually sell space in that app to advertisers. So there's millions of apps which have geolocation built into them. And you as a person give permission for your, if you like, your space on your device, your space in the app to receive advertising, and that's how they fund the apps. Kind of no such thing as a free lunch. So those locations and that information, and it's a number. You don't know who the person is. It's just basically a 15-letter encrypted number that shows a particular device. Now, with our tech stack, we're able to go deep into the infrastructure of the internet and go into the bidding systems that exist in a country for bidding on advertising for eyeballs on websites and apps. And we're able to pull that information down, and then we can actually go back up to 12 months. It really depends how much processing power you have and how much space in Amazon and how much money you want to pay. So the devices are anonymous. It's freely available. It's essentially public information, and it's all privacy compliant. It's just one of these massive things in the ecosystem nobody really thinks about. But the whole internet is run by massive, if you like, tech giants that are actually monetizing advertising on apps and on websites. So we just have plugged our AI into that ecosystem. We have a seated exchange. It is literally like the financial exchange, and you basically bid on eyeballs.
Great, yeah.
Slant to it. We're not bidding on eyeballs. We're actually using the eyeballs to use a different application. A bit like Bluetooth was never designed for what it's doing today. The ad tech ecosystem was never designed for COVID-19 tracing, but actually works beautifully.
Yeah, and obviously it's aggregated and it's all anonymized.
Yeah, aggregated, anonymous, yeah, it's source, absolutely.
Yeah. Okay, great. Thank you for that answer. Another question, different tack, which is around regulation. So we've seen that there's certainly in some markets, the regulatory environment's been a bit more relaxed. In the US, for example, the HIPAA data protection, some aspects of that have been relaxed, and India's relaxed some regulations around telehealth. Let's go back to Charles for this. I'm thinking about, I think, Charles, I heard earlier, you're active in both Asia, particularly China, and Europe. Have you seen any regulatory relaxation of the rules that's allowed you to do more?
In France, we have seen a significant improvement in telemedicine. If we think of last year, 2019, there were 40K telemedicine interview with doctors, when this year, during the past 2 months, it come from 40K to 4 million within the past 2 months. So significant increase, and government were pushing to develop this telemedicine and give more approval for telemedicine, because before you have to do a telemedicine with your family doctor only, but then it become more widespread with telemedicine hotliners, which was not permitted before. I also personally focus nowadays in a Korean market. We have a good positioning there. because before COVID, telemedicine, and we tried to penetrate the Korean market before COVID, it was very hard because telemedicine was not allowed by law, but it was temporarily open during the COVID. And as you know, Korea was best in class students in the world to show that, to show how they manage it without confinement or quarantine, without stopping the economy. So they still, I hope, want to continue on this journey of opening more telemedicine in more sustainable way. Those who were very opposed, like a medical association, hospital nurses, get some glimpse of the utility of telehealth, telemedicine, and some are more convinced today than before. And I hope that those who are in players of telehealth, telemedicine, like HealthTech or other, will have now a window shot to be a player in South Korea. Of course, in China, we have some players like Tencent Doctors or Ping An Doctors, or our partner is Jingdong Health. They have 1,000 doctors in their platform, and those big players had millions and millions of telemedicine calls. China is very open to that, and they want to lead the market in AI health. So since we have the big numbers of people here in China, it's quite easier to get the big data spectrum of I mean, in the database, to be able to get a big machine learning or other pattern recognition that can be more useful for diagnosis in the long run. So those countries that we follow has a big change. I would say we are also positioned in Singapore. To my personal point of view, I see that Singapore government is very, very smart to tackle the telemedicine, not only for those who has a treatment, but for those who are likely to develop that a generation before, like mid-age. They're very smart to tackle this telehealth and telemedicine.
Yes. And it seems very unlikely that the regulators are going to roll back some of this relaxation. I think they can see as much as everybody else, the benefits there are to the healthcare system. Perhaps just squeeze out that same question. We're almost out of time here, but to Carl, because you've been, you were talking about the Philippines and other markets that you've been active in. Have you, have you seen regulatory restrictions ease a little bit, and has that impacted your particular offering?
We haven't seen it ease. I think what we have seen is governments that are suddenly becoming more digitally literate / open-minded. I think the long-term impact will be felt probably in another, call it 18 to 24 months, where we see that new legislation is put into place to enable telehealth models, and the medical community itself becomes more of a promoter of technology as they realize the impact it can have on their ability to reach patients and also their own kind of lifestyle, work-life balance. But we certainly in this region, outside of Singapore, which I think is a much more nimble and forward-thinking government, I think the rest of the region has had its hands full with containing the initial, and in some cases still containing the first wave of COVID, to look at legislative or regulatory changes.
Great. Thanks, Carl. And thank you, all of you. We're out of time now. That was a really fascinating session. As with all these things, I wish we could have more time with you. With each of your areas, you're doing an amazing role there. Thank you so much for your time, and look forward to talking to you again in due course.